of the session. So we'll start with the first topic, which is the recalcitrant and refractive DME by Dr. Manjunath, Bhaskar, Anand, KUMAR.
Good morning, everyone. So the topic is recalcitrant diabetic macular edema. So there are certain things, words which in medicine which we need to change it. So something like pyrexia of unknown origin. So I think those words were designed initially when there were no much improvement in investigations or technology. Now one such word, what I believe is recalcitrant. So what I feel is more appropriate is non-responders. So if we carefully evaluate and find the reasons, we can definitely find out what is the reason why the patients are not responding to the macular edema. So myself, Dr. Manjunath BA, I'm working as a consultant at MM Joshi Ganesh Netralaya Eye Hospital, Shirsi, Karnataka. So what do you mean by recalcitrant? Recalcitrant is something like who is not responding, so disobedient. So this is going to be a presentation layout. So as per the definition, a DME refractory patient is the one who did not achieve complete resolution of the disease regardless of the treatment administration. Based on the OCT, so after this, even after the 6 months of continuous treatment, if your central foveal thickness is more than 250 microns associated with the visual loss, this is considered as a refractory or persistent diabetic macular edema. As per the DRCR.NET protocol, it has showed that more than 40% of the patients who were treated with ranibizumab did not achieve the complete resolution of macular edema. So the few good things which happened in these days is we understood the disease better, better technologies are available to visualize the DME, and we have more treatment options. So bad thing is sometimes in spite of all this, our treatment doesn't work and the edema remains refractory. So the treatment of DME is like a roller coaster drive actually. It's more like an emotional roller coaster drive. The videos are not playing. So whenever there is an increase in edema, we tend to treat. Whenever there is a decrease in edema, we tend to observe. This is more like a emotional roller coaster drive for a patient as well as a doctor. So this is the overlay of DME management. What are the options which are available? We have various anti-VEGFs, we have steroids, we have laser photocoagulation, and the surgery. These are the various options which are there in our portfolio. So this is a pathogenesis of DME which we are very much aware. So hyperglycemia leads to increase the free radical activity that results in the osmotic damage and ultimately capillary epithelial damage. So we need to know what is the reason behind these recalcitrants. So we need to find out various causes like what are the associated tractional elements in form of VMTs or epimacular tractions. This has come to use after having some of the advanced investigative modalities like SD-OCT, FA, and wide field fluorescein angiography. So what are the point you consider whenever you are treating a DME is like as a routine in any other DMEs is the baseline visual acuity, the duration, ocular environment as the local factors, are there any VMT or ERMs or any systemic factors. The main goal is to find a management pathway that will maximize the success and minimize the failure. So these are the various advances which took place in DME. So coming to systemic control, which is very much important, it's easy to remember in ABC. A stands for your HbA1c, anemia, 24-hour microalbuminemia. B for your blood pressure control. C for your creatinine and control of cholesterol. So this is what I have designed, like DME in treatment. You should ask your patients to follow this DME, like they should follow the diet, discipline, they should trust the doctor, medication, meditation, and they should be motivated properly, and ask them for exercise as well as education. So various options in brief we have for treating, especially in refractory DMEs. So switching of anti-VEGF. So all these topics will be covered in detail to other co-authors. So the rationale between the anti-VEGF is like there is a molecular difference between the molecules and the pharmacological targets of these agents. So corticosteroids, as we know, inflammation acts as a protagonist in DME. Inflammation occurs before the edema. DME may shift from primarily VEGF mediated in acute phase to the inflammatory in chronic phase. So whenever you treat with steroids, it will stabilize the blood-retinal barrier by downregulating the expression of VEGFs, inhibiting the production of prostaglandins and expression of inflammatory cytokines. So of course, lasers have been largely replaced, especially the focal lasers have been largely replaced by the anti-VEGFs. We no longer do focal lasers in foveal edema. Only in some cases like non-foveal edema, we try to treat them with focal lasers. So what is the role of PRP in diabetic macular edema? There have been some studies like DAVE studies which has been conducted, especially the targeted retinal photocoagulation in DMEs. Even in that, they have found that there is no much useful when they do only the targeted laser photocoagulation without using anti-VEGFs. So the new molecules which are there in our portfolio like brolucizumab. Brolucizumab is a very unique and small molecule, is known for better penetration, and it inhibits the larger VEGF molecules. So it has been found that it has 12 folds higher molecular dose than aflibercept in the same volume. So it binds with high affinity to all anti-VEGFs. So it has been found much more efficacy in compared to other molecules. They respond better in cases of recalcitrant DMEs. So there are two important studies which have been done like Castrol and Kite. So in that they have found that there is a superior reduction achieved with brolucizumab of 6 milligram compared to aflibercept 2 milligrams. So one more molecules which recently we are using is faricimab. Is the first intravitreal bi-specific monoclonal antibody. It inhibits both your angiopoietin 2 as well as VEGF-A. So it has been found that faricimab may extend the treatment interval for the patients with DME which are refractory to aflibercept as well as ranibizumab. So definitely there is a role for combination therapy, though helps in treatment of recalcitrant edema. It helps in extensive control of multiple the complex pathways which are involved in recalcitrant edemas. So whenever there is a taut highlight, you need to remove it, whether it's in the form of anterior-posterior as well as a tangential traction. You need to carefully look for it in the imaging, and you have to remove it surgically. So how does the surgery help? Surgery, helps in relieve the tractions in all the directions, and also relieves the vitreoxysis. So vitrectomy increases the oxygenation in the vitreous cavity up to 10 times. So PRP at the time of vitrectomy also helps in reducing the mid-peripheral ischemia. So these are the small videos, not playing actually. Routinely what we do is just do a core vitrectomy, induce the posterior highlight, stay in the ILM with brilliant blue, and you remove it as in routinely and in all other ILMs. The only thing you need to remember is the removing the ILM is not that easy as you remove it in macular holes. The ILMs are quite sticky, so it will come like in a piecemeal. So these are a few images just to show the pre and post, how the removing the tractional elements will help in responding to the treatment. Even what we have found is after removing this traction, even with anti-VEGFs or any other molecule which we used to use previously, they respond better after removing the tractions. So newer frontiers like ROCK inhibitors, neuroprotective agent, mTOR inhibitors are in the pipeline. So at present, the standard of care is definitely a combination therapy. Sustained release devices and micropulse lasers are interesting and potentially promising. The holy grail would be method to improve or reverse the macular ischemia. Macular lasers is no longer a gold standard for treatment. So posterior highlight management is vital for treatment of a chronic condition. So tailored approach based on the genetic profile could be a future. So 1/3 are non-responders or recalcitrant. Good metabolic control improves the outcome in all the DMEs. Recalcitrant DME requires alternate therapy with steroids or prolonged monthly anti-VEGFs. Vitreous surgery is required in tractional DME. So with this, I think you can make your DME obedient for your treatment. Thank you.